Thank you for sticking around. This is a long day for everyone. Today we're going to focus on accessing healthcare for adults with autism, and we have 4 presentations, each about 15 minutes. I would first give a short introduction on the comorbidities, both medically and psychiatrically, for this population. And then Dr. Lisa Croen from Kaiser is going to share her insights on the interactions between the providers in Kaiser with the adults with autism using the data from her survey. And then Dr. Clarissa Kripke from UCSF will talk about a lot of potential resources and tools that can be helpful for accessing medical care for this population. And then finally, we'll have Dr. Karen Fessel, who will talk about the Autism Insurance Project. So let me quickly go to the first presentation. Okay. So I'm going to talk about psychiatric and medical challenges in adults with autism. So there are 9 studies that are published coming from 4 different countries, including the study that Dr. Croen has conducted at Kaiser, as well as some other studies from Sweden, from Netherlands, and Germany. And by far, the Kaiser study is the largest study involving over 1,500 adults with autism, comparing with over 15,000 control subjects. They are basically patients that are selected from, randomly selected from the 1.5 million members of Kaiser. Basically, this group is relatively young. It's about 29 years old, plus or minus 12 years. One thing that I want to bring up is that the different studies here have different proportion of individuals with intellectual disability. And in Dr. Croen's study, there's 22% of them that have intellectual disability. The Buck study from Utah has 76%. And Cervantes has basically the entire population with the entire study with intellectual disability. And then the rest, actually, they are all high-functioning adults. So when you're thinking about dividing the two with intellectual disability and no intellectual disability, it will be a little bit more clear on what comorbidities we are actually dealing with. So first talk about Dr. Croen's study. This is a table from her paper. And very clearly, we can see that anxiety and depression are the most prevalent in this population. And we can see that this is a group, not a pure group of adults without intellectual disability, but most of them, 78% of them, do not have intellectual disability. And by the numbers, you can see 29% with anxiety disorder and 25% with depression. And worth noting also is when you're looking at the odds ratio, that means when the odds ratio is higher, then that means the comorbidity is more prevalent in ASD. And you can see that ADHD, bipolar disorder, OCD, schizophrenic disorder, and suicidal attempts are actually quite high when you look at how serious this problem is. On the flip side, actually, for alcohol and substance abuse, or dependence, there is actually less of a problem. The Buck study from University of Utah, they have another group of patients. This group of patients, as I mentioned, has a higher number, is 78% of them have intellectual disability. And this is a group also having a higher age group. And what we can see here is that the most prevalent in this particular group is anxiety and OCD instead of anxiety and depression. Looking at the remaining, the 4 studies that I handpicked here are the studies that are focusing on high-functioning adults with autism. And basically, very clearly, you can see that mood disorder and anxiety disorder are basically the most prevalent when you're looking at the high-functioning group. So kind of similar to what Dr. Croen's study is concluding. And when you're looking at not only the current diagnosis, also the lifetime diagnosis, a similar kind of conclusion. One thing that you can see is that without intellectual disability, so this group is actually from the Boston group. So when we are looking at the autism or adults with autism without intellectual disability, there are actually more psychiatric diagnoses than without the ASD diagnosis. So what is showing here is this is the current psychiatric diagnosis or comorbidities for the ASD group. There are 3 of them for ASD group, but only 1.5 for the non-ASD group. This slide basically shows us another dimension of how we can look at this problem. So the older adults with autism have more comorbidities. This slide is a little bit hard to kind of just understand right away, but basically this is the x-axis here is the number of psychiatric diagnoses. The red is the younger adults with autism. The green is the middle-aged adults with autism, and then the kind of dark purple is the older adults with autism. So as you can imagine, the control group, which is basically the non-psychiatric group, the non-ASD group, most of them do not have any diagnosis, so it's 0. So about 50 to 60% of them, regardless of age. But when you're looking at the autism group, one interesting fact is that the older individuals with autism actually is the group that have more of them that have no psychiatric diagnosis. So other than age, we are also thinking about gender. And if we are going back to anxiety and depression, you can see that there is a higher percentage of individuals with a higher number of women with ASD having anxiety and depression compared to the male counterparts. So now I'm going to talk about the medical comorbidities. There are 4 studies here, including Dr. Croen's study, and this is a study from Children's Hospital. And they have a very large sample size. They included a lot of individuals from their electronic medical records from 4 different hospitals in Boston. And basically what they are trying to see from this is actually children plus the young adults. Not only young adults, but when they are separating the two, they have basically similar results. So I'm just going to keep everybody both the children and young adults in this particular graph. And what you're seeing here is the darker bars represent the percentage of the individuals with autism that have an additional comorbid diagnosis. So for example, in here, epilepsy, about 19% of the individuals with autism also have epilepsy in this particular study. And when you're looking at the just the individuals with autism and the medical comorbidity, the biggest one is epilepsy. And then you can see that there is CNS abnormalities as well as bowel disorders. And when you're flipping it the other way, then that means you're looking at people with the individual medical problem and figure out how prevalent it is. The individual medical diagnosis also carry a comorbid autism diagnosis. Then you can see here that Fragile X syndrome, which is a neurogenetic syndrome that we know is a known cause of autism. 21% of them also carry the diagnosis of autism. And here is tuberous sclerosis, as well as some sleep disorders, schizophrenia, muscular dystrophy, etc. So the next few slides, basically, well, we're just going to really focus on one kind of system at a time, and this slide is on the neurologic diseases. This is from Dr. Croen's study again, and basically, when we are looking at all of the individuals with autism, and in this case, it's all adults with autism. About 40% of them have the diagnosis in this particular study. And about 22%, it's almost half, is in the control group. And other disorders of CNS here is kind of not specific, so I'm going to skip it. Epilepsy, as we talk about it, about 12% in this particular cohort for the autism group. And very, very small numbers, less than 1% in the control group have epilepsy. When we look at kind of like the flip side, like what's actually not higher in the ASD group as compared to the control group. Basically, in terms of headache, migraines, individuals with autism do not have more headaches, and as well as the disorders of peripheral nervous system. It is also no difference between the ASD group and the rest of the population. And then the next system is our gastrointestinal system, and the most prevalent one is gastroesophageal reflux disease. About 13% of the individuals with autism have this diagnosis versus 7.7% in the control comparison group. The second one that is highest is upper gastrointestinal motility problem. About 8% of the ASD group has this diagnosis, and less than, is about half of this number is present in the control group. And when we are looking at the flip side, there are also a few disorders involving the gastrointestinal tract that have basically no difference between the two groups. And the next thing is immune disorders, allergy, autoimmune disease, and asthma. You can see there's some difference, but there is not dramatically different like the previous slides. Sleep disorders, however, is actually quite common. you can see about a twofold higher in the ASD group. And then, interestingly, hypertension and cholesterol problem, there is more in the ASD group. Obesity is a little bit higher in the ASD group, and diabetes is also higher in the ASD group. I'm going to skip this slide for the sake of time, but basically to conclude, it seems like when we look at the group with ASD and intellectual disability, anxiety and OCD are the most common comorbid diagnosis. And in the high-functioning group with ASD, depression and anxiety are the most common. And it seems like there is a trend to see that there is fewer psychiatric problems in older adults with autism. There's only one study, so we can't say for sure. There are more data coming out from various groups around the country. And in terms of the medical comorbidities, epilepsy is the most common comorbid neurologic disorders in adults with ASD. And there is a really big group of disorders, that involve a few different organ systems that seem to be more common in adults with autism. So very quickly, just to give a plug on our research studies, there's a clinical trial on pregnenolone for adolescents and young adults with autism, as well as a neuroimaging study. And that's it. So I'm going to just introduce Dr. Lisa Croen. Dr. Lisa Croen is a senior research scientist at Kaiser Permanente. He is the director of the research. She is director of research in Kaiser research autism research program.
Thank you, and good afternoon, everybody. So Dr. Fung just spent some time going over the medical issues and co-occurring conditions that we often see in adults with autism spectrum disorders. I'm going to look at the other side of the equation, which is the providers, the clinicians who are caring for these adults. And what we really were interested in is what do they know about autism? What is their experience in caring for patients with autism? What resources do they need? What questions do they have, and so on. So we were able to conduct this study within Kaiser Permanente, where I work, and just as a quick introduction, I think this goes without saying that we know that the rate of autism is increasing by leaps and bounds and has been over the last 2 or 3 decades. The most recent estimates from the CDC are that 1 in 68 children at age 8 have a diagnosis of autism, and this is basically across the country. Children grow up to be adults, and children with autism usually grow up to be adults with autism. So it's really critical that the people who are taking care of these adult patients have some kind of understanding and recognition and skill set to be able to provide the best medical care possible for these adults, and as they transition into the adult medicine system and as they age into older age. So this is again just a quick summary of what Dr. Fung presented. This is from our study, basically underscoring that adults with autism not only have much higher rates of psychiatric conditions. He talked about anxiety and depression, and in our system we found a quite dramatically higher rate of suicide attempts among adults with autism compared to their non-autistic counterparts. So some of these suicide attempts were even in patients who did not have a diagnosis of depression. So it means that we're missing, some of the comorbidities that are affecting these patients, and sometimes it gets so critical that that they're in a very serious strait. So that this is a critical area to address. But not only are the psychiatric comorbidities higher, but many different medical comorbidities are higher. And I've just listed some here. You just heard Dr. Fung talk about gastrointestinal disorders, hypertension and diabetes, obesity, sleep disorders. Many of the conditions that we find that are elevated in children also are elevated in adults with autism. So they have big needs and need to be taken care of, and these conditions need to be taken care of by their adult clinical providers. So we did a very brief survey to try to assess the knowledge and experience of experience with ASD among our adult healthcare providers within Kaiser Permanente. And the goals really were to determine their general knowledge about ASD, their comfort level in treating patients with autism spectrum disorders, and to gauge their specific needs in caring for these patients. Here, probably many of you may be members of Kaiser. It's a group practice, pre-paid integrated health program where the doctors work, the insurance company, the providers, the clinical providers, and the facilities are all integrated. They're actually different companies, but they're all integrated, and a member of Kaiser gets all of their care, psychiatric as well as medical care, laboratory, pharmacy, that kind of thing in the system. And we have a very elaborate electronic medical record, so it's fairly easy to look at existing databases to look at rates of different conditions in different types of populations. We cover currently about almost 4 million members, so it's a very large population. You can see the area in Northern California where Northern California Kaiser is covered. And it's a very, not only geographically, but also ethnically and racially diverse population. So it's a good sort of, we feel safe in generalizing what we see in this Kaiser population, for the most part, is very representative of what's happening out there in the general population, more or less. So we designed a very, very brief survey. We wanted as many of the busy clinicians to answer this survey as possible. And so we came up with a brief survey of 11 questions that was designed by a multidisciplinary work group. Dr. Kripke was on that work group, as well as we had some patient advocates, adults or parents of adults with autism, different kinds of clinicians, researchers, and service providers who got together over a period of months to talk about this project, and also guided the project the study that Dr. Fung had presented on the comorbidities. And we basically administered this brief online survey to family and internal medicine providers, to adult mental health providers, and to OBGYN providers. And it was, you can add that up. It was over 2,000, 2,000 to 3,000 people that we surveyed, that we invited to answer this survey, and they included physicians, psychologists, social workers, and nurses. And it was sent basically online, sent as an email, link in an email by the chief of their department. So we're hoping that people would listen, would answer those emails more than if some random researcher sent them something. So we actually got a very large number of respondents. We got 922 people who answered the survey, and you can see here how they distribute in terms of the department they came from. The majority were from adult and family medicine, then fewer from OBGYN, and in the middle from mental health. And one of the striking things was, one of the questions we asked them was, how many people do you suspect have autism, or do you know have autism, who are in your panel? So each of these physicians have a panel of patients of maybe 2,000 or 3,000 people, a large number of people. But what was very evident across all those different kinds of providers was that the number that providers thought they had was way lower than the number they actually had. And so, that could be explained by many things. They may not be aware that their patient has autism. Those patients with autism may not be coming in to see them very often. You can see many things. But by and large, there was a huge number, underreporting of the number of patients they had. So they don't make too much of a, out of a panel of 2,000, if you have 10 patients, you might not remember those 10. But nonetheless, these patients have special healthcare needs, and you'll see in a minute that they may not be getting addressed adequately. When we asked the providers, how would you rate your knowledge and or skills in providing care to people with autism, this wasn't surprising, but it's good to have data. The very good to excellent was less than 10%. So less than 10% of all providers, and even the mental health providers, said their knowledge or skills in providing care to patients with autism was poor, was very poor, or less than 10% said it was very good to excellent, or nearly 50%, or more than 50% said it was fair to poor. So this is self-rating, and I think if anything, that's going to be inflated toward the positive side. So this, very few people feel competent in caring for patients with autism. Then we asked, do you have adequate tools or referral resources or practice models to accommodate people with autism in your practice? And again, fewer than 20% on the whole agreed with that statement, and said the other way, 40 to 70% of the providers disagreed that they had adequate tools and resources to accommodate their patients with autism. And interestingly, the mental health providers, who probably are most equipped, and have most experience, they were the ones who, 70% of them said they disagreed that they had adequate tools. Then when we asked them what kind of training or resources would be useful to you, all of the choices we gave were highly endorsed. 60, 70% or more of the physicians and the clinicians endorsed many of these things, having an ASD conference, having a list available, a checklist of community resources. Training on effective communication strategies with patients was very popular, and also we provided this option of having a special clinic for adults with developmental disabilities, and that was also quite a popular choice. And you're going to hear in a minute, I think, from Dr. Kripke about some models that she's developed for that. Then when you suspect a patient with autism, when you suspect autism in a patient, what do you do? The OBGYN providers said, a large number of them said, we provide usual care, we don't do anything special. It's really not, they don't feel like that's in their bailiwick. And that's an interesting thing, and I think there's a chance for training for all of these providers, but especially with the OBGYN providers, is we have found that the use of pap smears, some preventive medicine, in women is really low, in women with autism is really low compared to their non-autistic counterparts. So, I think there's room for having some special training and some special accommodations in OBGYN, so we make sure these women are getting adequate care. And then there was some an ability for people to write some comments, and what was really striking here was that several people, not just one or two, but several, and these are adult providers, said, they basically indicated they had no awareness that autism occurs in adults, because they wrote things like, well, I don't work with kids, so, this doesn't apply to me. I haven't ever encountered ASD. Again, that's a little bit discouraging. So then, quickly, we were able to do some follow-up interviews. These were qualitative, open-ended interviews with some of these clinicians. Surprisingly, out of the 922 providers who answered the survey, about 40% said they would be willing to be interviewed over the telephone in a short interview, which blew my mind. I thought we would get maybe 10 or 15 people who would actually be willing to give time. But that indicated to me that many of them have a lot to say, and they're really looking for some help and input of how to provide good care for these patients. So we were able to interview 9, and we basically we focused on their training and to ask them to describe what's a typical office visit with one of your patients with autism. Let's talk about the physician-patient interaction and so forth. And there were three kind of main themes, or three of many themes that came up, but three that I'll describe here. One of them was, this was summed up by a physician who said, when we asked what kind of medical training or education or resources have you been given or have you had, and he said 0 to none. So most of these providers, even if they're more recently trained, don't have any official training on autism or developmental disabilities, I think, in medical school and their post-graduate training. Do you make any special accommodations? And one woman went on and on about what she does, but basically it was summed up with, it takes a slow approach. She said, I have to, speak more slowly and in smaller bites and have longer pauses and, maybe sit side by side with my patient and where we're both looking at the wall across instead of me trying to engage them, face to face. And I know that Dr. Kripke is going to talk more about this as well, I think. And then the challenges. One of the interesting things was a lot of providers, or some of these who we interviewed, said, they said, oh gosh, I guess I should, but I don't really ever ask these routine questions about lifestyle-related issues like drugs and smoking and sex. They just sort of assume none of that is happening or it's off limits, and they don't even bring that up. People said the challenges are the impairment level and communication and involving the parents and if this custodial or guardianship conservatorship, arrangements where sometimes the parents aren't invited into the room and the patient can't speak for themselves, and so on and so forth. And one of the big things that came up was the transition from pediatric to adult medicine. And so we're now doing another study looking at that transition specifically, and again, interviewing patients and providers and some care managers and also caregivers, and to try to understand what's really happening around the time of transition and how can we make that transition better. So I think, what's needed, probably none of this comes as any surprise to all of you who maybe have young adult or older adult children with autism and struggling with the medical system. We wanted to do this to document it and to have evidence, and then to be able to use this evidence to go to our leadership and say, okay, we need to provide training for our providers. We need better, even in a system like Kaiser where it is an integrated system, we need much better integration between pediatric and adult medicine. That transition is a real falling off the cliff kind of experience for many people. And we need much better integration between the mental health and the medical departments. Provider training and resources are really critical and have to be specific to the type of provider. And then finally, to have some effective tools to improve this patient-provider interaction. And specifically, I think what would go the longest is special training on how to communicate, on communication with patients who have communication who are less equipped, and training on effective communication strategies would really be, if I had to pick one thing, I think that would be the first thing that we would push our people to do. Okay, and I just want to acknowledge my team, and thank you very much.
Thank you, Dr. Croen. By the way, today is Dr. Croen's birthday. Our next speaker is Dr. Clarissa Kripke. She is a family physician, also a clinical professor of family and community medicine, as well as director of the Office of Developmental Primary Care.
Hi, thank you. Can you hear me? So I have nothing to disclose, and I want to thank my funders, including Special Hope Foundation, the Shaw Family Fund, and Regional Center funders. So imagine how you would feel if you couldn't make the choices in your own life, if you couldn't decide where you wanted to live and who you lived with, and if you couldn't make your own decisions about your own health care. this happens too often to people with disabilities, but it doesn't have to be that way. And we have a CART mobile consult team, which serves Northern California, and we serve regional center clients who, from our supporting regional centers, the 6 regional centers in Northern California, and we're committed to supporting people to live as healthy as possible, even people with the most complex disabilities, with communication problems, with behavioral problems, to live successfully in the community of their choice. Congregate care and clustered care settings can interfere with choice and control, and they can put people at risk. They're not intended, I just want to say that sometimes people are afraid that if people are living out in the community that they'll be unsafe, but I want you to know that we can and are supporting people with the most complex disabilities, people who've been formally institutionalized, people who have aggressive behaviors, people with commitments to the criminal justice system, people who are medically fragile, people who need 24-hour nursing, people who are on ventilators. We're serving them all in the community. It can be done, and it can be done well and beautifully. So how do we achieve this? Well, you start with the person, with supported decision making. Supported decision, we've heard a lot about conservatorships, but supported decision making is an alternative to conservatorship that allows people with disabilities to retain their legal capacity. And that's true even if sometimes for some decisions in some situations, or even for many situations, they don't have the mental capacity to make an informed decision. Individuals can choose supporters, which is actually a very low level of capacity. It's just an authorization to help them understand the situations that they face and the choices that they can make. So people can choose a supporter even if they need a lot of support to make their own decisions, and for us to help determine their will and preferences. And it empowers people with disabilities to take a more active role in their health care and to make decisions with support. And that ensures that your loved one also can have access to support even if you're not the one who's able to provide it, and none of us are going to be able to provide support forever. And the people that we have in succession may or may not be available or may not be willing to do that when it's necessary. So this is a much less complicated process to use supported decision making. It's actually how most regional center clients currently operate. Most of my patients, and I have many patients whose parents have passed away long ago and aren't involved in their life, are unconserved, and many of them have very, very little capacity to self-direct, and it works just fine. There's been a lot said about regional centers. I have a lot of respect for the regional centers and for the work that they do and for the process that they use when supporting decisions, especially around healthcare, when they come up. And I've never been in a team meeting where a regional center was called upon to make a decision where they didn't do their best to identify family members or concerned circle of support members and bring them in, and we're very deferential to those people when they had strong opinions. There's fear that the government or the regional center is going to come and take away your rights or do something, but in my experience, I've never seen that happen. It's always been a process where anybody who is involved in that person's life will be very welcome to participate in helping to support the decisions and helping to achieve a good outcome. In order to self-direct your own life, in order to achieve good health outcomes, communication is the foundation of patient care. About 80% of making a diagnosis is about communication. And a lot of the folks we work with have communication disorders of different sorts. But remember that communication is a two-way street, and that how we listen is just as important or often more important than how someone expresses themselves. And I believe and operate with the philosophy that everybody communicates, and we need to find a way to presume competence to understand that people have a right to participate in the decisions that affect them, and that those decisions, when they do that, tend to be better and they tend to be healthier. And a lot of the behavioral problems and the health problems that we find are because we're not listening. And if we listen better, if we support the communication better, we'll achieve better outcomes. Now, I'm not unrealistic. Of course, I take care of very complex people, and sometimes you really can't determine someone's will and preferences, no matter how hard you try today. But that doesn't mean it won't be true next day. The way we learn to communicate, the way we learn to make decisions is by going through the process. So just because today you needed to make a substituted decision, the best you could, doesn't mean that tomorrow somebody won't be able to do that better themselves. In fact, that's how people learn, and they learn from their mistakes too. So sometimes when people make bad decisions, it's not necessarily a bad thing for people to take responsibility for knowing that if you make this decision, we're going to respect it, and there's going to be consequences, and you're going to live with them, and that's how we all learn not to make a mistake again. So one important thing when trying to access health care is to make sure that your doctors know how to communicate as well as they can, that they know who those team members are who need to be involved, especially if there's if there's a supported decision-making agreement or other paperwork. But even if there isn't, who are those people that need to be involved in that support? If you don't tell them, they're not going to know, and then you can't complain that you weren't called. They also need to know what the baseline is, because all of the folks that we serve, all of our family members are different, and people can't make assumptions just because you have a diagnosis of autism. It tells you very little about your intellect, your neuromotor skills, your seizure thresholds, your behavior, your sensory profile. If you don't share that information, then it won't be known. So there are some, and if you need accommodations, if you need a longer appointment time, if you need someone to communicate in a different way, or if you need the lights turned off because the fluorescent lights are a problem, or whatever it is you need, there are 2 tools here. There's a healthcare passport in the handouts. There are links to many more resources. And the Aspire Toolkit, the Aspire Toolkit, I think has a lot, it's a website, it has a lot of good resources, but it also has a tool for creating your own accommodation letter to bring to a doctor. And I think it's especially good for people who can provide that input. The healthcare passport that's on our website is good for people who have higher support needs and who may need someone to help them more with providing that information. In terms of behavior supports, I know a lot of us are working with challenging behaviors, sometimes self-injurious behaviors. Those behaviors don't last forever, and we do need some new service models, and we're working on developing them. When I see this succeed with the most complicated situations, it really requires a whole person approach, not just a behaviorist approach. You want someone who has a very broad perspective at the head of the team. Behaviorists are really important members of the team, but they're only a member because we need to look at the whole situation, the social environment, the physical environment, the healthcare issues that are going on, the housing, to figure out what's really going on and what's going to make the situation better. We need to use a range of support methods, not just behavioral methods. Trauma-informed thinking, not what's wrong with you and, do we have a pill to fix it, but what happened to you. Trauma, whether we're aware of it or not, or whether we realize it or not, is pretty universal among our folks. You just can't live with a complex disability in our society and not have experienced some of it. So we really need to take that into account and be very gentle and compassionate in how we approach people. And like I said, choice and control of one's life. one's own home, and especially the people who are providing your direct support, being able to choose the people who are providing your direct support, having input into the people who are providing your direct support is absolutely critical to your health and to your behavior and to your overall happiness. So this is a dysfunctional cycle that can get going in people with the most complex needs. People have a behavioral crisis. It overwhelms either the family or the care providers. They call 911. They end up in the hospital. Their home no longer feels like they can manage, so they go to a crisis home or some temporary place, and then a new home is created, and then the cycle starts all over again. One of the new models that we need is more of an enhanced supported living model, where we break the cycle so that we don't pair people's housing and their supports, because when you pair housing and supports, then you don't have choice and control over who's providing your care. And if your care needs change, you lose your housing at the same time that you're having a crisis, and that's a very bad situation to put people in. So this is a different model where people have stable housing that they control, and then we add the supported living team and the expert clinical team to that, and that expert clinical team can follow people across settings. So you don't go to the hospital where nobody knows you and then have a behavioral crisis and have someone manage it, who a policeman manage it. That's a terrible crisis plan to be calling 911 and having cops manage a behavioral crisis that could be a medical crisis. Then you have a different team in the hospital. There's so much discontinuity in that system that it just doesn't work. But we can create better systems that work for people who have the most complex needs and who are cycling in and out of the hospital. Also, we need to think about end-of-life planning. One of the things we need to monitor the most carefully is cultural shifts in attitudes towards disability, and you start hearing this a lot. Dehumanizing language, fear, suffering, tragic, all these kinds of words that epidemic that are ascribed to autistic people, and every time there's an episode of violence, whether an autistic person had anything to do with it or not, there's speculation that anybody who must have done this must be autistic or might be autistic, and that kind of media messaging is very dangerous to our people. It really impacts how people think about our loved ones as potential employees, potential neighbors, potential classmates. And when we hear these kinds of words and dehumanizing ways of describing our loved ones, we really need to speak out. Excuse me. And I think of advanced care planning and a POLST, the physician's orders for life-sustaining treatment, as critical documents, even for younger people, even for people who don't have any terminal illnesses, because even if what your documents say is that we affirm life, we affirm that we have a good quality of life. If your loved one ends up in an emergency room and they look sick and they have all the stigma around them, if people can make assumptions about their quality of life and not provide care when it's needed, and think that they're doing something merciful. So we need to really guard against that and be aware of that and fight those attitudes when we hear them. So CART services, we're here for you, and I hope you'll call us. We will do phone and email consults and have a limited capacity to do full comprehensive consults. And we have a lot of resources on our website and on the handout that's online and on the table outside. We have a ton of stuff for you, transition guides and more information on supported decision making and all sorts of stuff. So thank you.
Thank you, Dr. Kripke. Our next speaker is Dr. Karen Fessel. She is the founder and executive director of the Autism Health Insurance Project.
Thank you. Okay, yes. So I was asked to talk about behavioral health services for adults. And so to me, it's the next frontier. It's like our organization has been involved in fighting for children for many, many years to get this service and then to make it a reality for them, to actually make sure that it happens. We're a nonprofit public charity, and we were formed when parents came together and we realized that the healthcare system really wasn't providing a lot of services for our children with autistic spectrum disorders. They were getting services from the school, they were getting some services through the regional centers, but they were getting very little from their healthcare system. So our mission is to help families and professionals and people with ASDs get the services that they need through their health plans so that they can ultimately reach their full potential. So we offer free advice on how to handle denials when your health plans actually deny services. We do appeal writing, and we do independent medical review requests, and we help families with regulatory intervention. Our state regulators provide a lot of support, and we've kind of beaten them into shape over the years, and they finally understand autism. To a certain extent. We provide updates on changes in laws that impact our families through our quarterly newsletter and our website. And we're on the brink of a change, obviously, with the change of administration. We're on the big brink of a change, and we really don't know what lies ahead. But please stay in touch, and we're going to do our best to keep you guys in the loop. And anybody that wants to get involved, we want to hear from you as well. A big part of what we do is we educate legislators and state regulators on the needs of our families. So this is a photo of, on the top, Feda Al-Malidi. A lot of you know her. She's an advocate, very active in the community. Myself, my son Aaron, and in between us is Dave Jones. And he's our insurance commissioner. He's probably going to be running for Attorney General, and he's been a really good friend to the autism community. He's been very helpful. He's issued a number of regulations that have helped our people. And then below is a picture of Feda with Jerry Brown. Feda she's a board member. She doesn't take no for an answer. And while she was snapping that selfie, he said, "Oh, if I let you do that, everybody's going to want to do it." And she didn't take no for an answer. She snapped the selfie. It was on the cover of the Los Angeles Times, and it said, "Now Governor Brown takes selfies," something to that effect. Anyway, so we educate families, physicians, and other professionals through community-based workshops basically on the services that our loved ones with autism can get through their health plans. So there are several different types of health plans. This is a little snapshot of the California population under 65 by the different types of insurance that they have. And in blue and orange are privately regulated, state-regulated plans. So it's about half of the population have a private plan. The light blue is self-insured plans. These are when you work for a large company. Often the large company pays out the claims, and they get to make a lot of decisions about what's covered and what's not. And then, that's interesting. The purple, it says category name. I don't know what happened there. So the purple is uninsured, and that's down to 7%. It was 18% shortly before the Healthcare Reform Act went into place. And hopefully we will keep that, and we won't see those numbers dwindling. And then Medi-Cal is about 18%, and Medicare is 2%. So So why does it matter? Why am I telling you all this? Well, it does matter. How you get your insurance does matter in terms of how things are covered. For commercial private pay, fully funded, those are plans that are regulated by the state. From the previous slide, it was the orange and the dark blue. If you have a fully funded plan, your adult loved one with autism get certain autism protections under the autism mandate. And it's known as AB 796. This is the most recent version that passed last year. And so, and then there's also a California state law that offers certain protections called the State Parity Act, and then there's also the Federal Mental Health Parity Act. And the point about these is that there's no age limits allowed on certain autism treatments. And so they can't just say you're 25 and we're not going to cover things like behavioral health therapy or speech therapy. They can say that there's not a lot of medical evidence that supports it, and that's like there's a growing body of medical evidence that supports it. We need more studies to support behavioral health therapy for adults, but they can't just categorically say it stops. Now, if you have a self-insured plan, if you're in this 27% of the light blue and you're getting your insurance through your health plan, through your employer, and they're paying out the claims, so some people get insurance through their employer, but they're small employers and they're state regulated. It's a little bit complicated. Anyway, if you have a self-insured plan, they are bound to federal mental health parity, but and age limits are a violation. However, many still exclude behavioral health treatments for autism. And so a lot of your families can't get services. And recently developed regulations. Now, where does Medi-Cal? Because obviously that's where a lot of our adult children are funded through Medi-Cal. And where is Medi-Cal in all this equation? Well, behavioral health therapy is now available to California children, but it's a child-only program, and it stops at age 21. And so, when your kids hit 21, this is no longer available through Medicaid or Medi-Cal. And there were recent regulations that came out from the task force to government, the mental health task force to President Obama, and they basically summarized how Medicaid will apply, how the Federal Mental Health Parity Act, will apply to the Medicaid population. So there are some protections, but they're somewhat limited. So who gets Medi-Cal? It's a joint federal and state program. Medi-Cal serves low-income families, pregnant women, people with disabilities, children in foster care, seniors, those with waivers that we've talked a lot about today. And then due to the Affordable Care Act, it also covers low-income adults without employment-related insurance and children up to 265% of the federal poverty level. Now, will these people be able to continue to access these services with the new administration? We don't know. It's a big question mark, and there are a lot of things that are changing. So there's many paths to Medi-Cal. I think we've heard about some of them today. For those with developmental disabilities who qualify for regional center, they can get a Medicaid waiver through regional center. For adults who, and there are certain conditions, you're supposed to have at least one service. For adults who do not qualify for regional center but have been unable to work due to other factors, Medi-Cal is available through SSI. And then also, if you just have plain low income, you can get it, adults, and that's relatively new. There's a wonderful resource right there on the bottom, db101.org, and it has a lot of information about how to access public benefits. Very useful. What benefits can be covered through Medi-Cal for adults currently? Well, there's something called the CBAS, Community-Based Adult Services. They're usually center-based, and they're supposed to include speech, OT, PT, social services, meals, skilled nursing if needed, and caregiver support. Now, this is in the manuals. I looked in like several different manuals. for Medi-Cal. Okay, I'm at 5 minutes. And you're supposed to be able to get them. Whether it's a reality or not, I don't know. I haven't heard a lot of people talk about them, but it's a legal right. In-home support services, we've talked about that a lot. Mental health evaluation and therapy. Now, with Medicaid, it's typically carved out to county mental health. I've heard many stories of people with developmental disabilities going to county mental health and being turned away and being told that they can't get services there because they're not equipped to handle people with developmental disabilities. Well, this is illegal, and it's probably the basis for a class action, I would love to discuss it with County Legal Aid or Disability Rights California. If your loved one has been turned away, it's illegal for them to do so, and we do hear about it. So what about behavioral health for adults? Well, this whole thing, it came about for children due to lawsuits in several states. The federal government got tired of defending those lawsuits, and they advised the states to provide the service to children. But it ends at age 21. So what can adults do? Well, we recommend someone at the statewide Council on Developmental Disabilities is not taking no for an answer, and we're currently investigating developing a state bill to offer behavior intervention services through Medi-Cal for adults. And it's very exciting. I attended a meeting last week. We're going to meet again. We need a funding source. Governor Brown is very conservative in his funding choices, and when he approves public benefits, he wants to know where the money is coming from, and he doesn't want to take it from the general fund. So that's the current challenge. If people have thoughts or ideas, I'm very open to hearing about it. In light of cutbacks, we don't know if it will pass, and we also are going to need more efficacy showing that behavioral health therapy is effective for adults. Regional centers are still on the line. They don't provide a standard ABA, it's typically less hours. Some of this was discussed this morning. Some regional centers provide a form of behavioral therapy. A lot of it involves getting the caregiver, the primary caregiver, to implement it. It's not evidence-based, and regional centers are supposed to be providing evidence-based services. So this is something that somebody might want to hire Jim or attorneys to take on as well. Keep your adult child on your family plan. If they have significant disabilities, they can stay on beyond the age of 26. Okay, that age of 26 is for your typical kids. If you can afford to buy an individual plan, it's open till the 31st of January. You can do that for your adult child if you can afford it. There are no age limits in the private system, and you can buy an individual plan that has the benefits. And then, is there a potential class action against Medi-Cal for denying behavior therapy for adults with autism? Maybe. And something else that's important to know, our legislative leaders, these are our legislative leaders in Sacramento, and they came out the day after Trump was elected, and they made a big statement saying that they're not going to let they're going to defend people in California and not allow the election to reverse generations of progress at the height of our historic diversity, scientific advancement, economic output, and sense of global responsibility. So your job is to remind them that they made a promise to try to keep things the way they are here in California. If you've benefited from healthcare reform, share your stories. Talk to the press. Get to know your state and federal representatives. If you have trouble accessing public benefits, your Congress people are supposed to be able, they have an Office of Constituent Services, as do your assembly members and your state senators. So take your problems to them and tell them about it. Competent healthcare is a right. Do not take no for an answer. And this is just a slide I put in, and it's basically to explain the relationship between secondary insurance. A lot of families have Medi-Cal as secondary. It's always going to be secondary. The way to make it work with your private insurance is to find providers that accept Medi-Cal and your private insurance. And that's not always an easy thing, but when you do that, you can pretty much get your services covered at 100%. Read your plan manuals, and here are some important tools. Those of you that are taking pictures, there's some good links on a lot of these sites. We have some sample letters if you're having trouble getting services. We have sample letters on our site under Medi-Cal. This, let's see, Rights Under Lanterman. There's an amazing document developed by Disability Rights California, and it has tons of information on how to access the regional center system. dmhc.ca.gov. That is how you access our state regulators. They are familiar with autism. They sometimes put themselves out and help our families. And then these are some plans, some health plan manuals that explain what your rights are. I tried to use the ones for you guys in this general area if your loved one is on Medi-Cal. And these are some user groups that we've developed, and you can ask people for names of providers in your area and that take certain kinds of insurance. And a lot of people, we have one for Kaiser as well on where to get providers that know how to deal with our loved ones. DHCS, they have a special email for questions about behavioral health, abainfo@dhcs.ca.gov. Subscribe to our newsletter. We're trying to keep up with the changes that are down the pike. So that's it for my presentation. I went over time a little. Thank you.
I think we have about 4 minutes for questions. Dr. Feinstein.
Well, I'm a psychiatrist, but this is actually a medical question. I'm not sure. I think it's probably question for Dr. Kripke, but it could be for others too. When we're talking about adults and older adults with intellectual disability and autism, whose parents have died and who don't have conservatorship, and I am left sort of absolutely having no idea what would happen if who makes the decisions about, let's say, someone has cancer or breast cancer, and all kinds of complicated decisions have to be made that are very, very difficult for fully educated, high-functioning people to make, or a knee problem, an orthopedic problem where there's many different choices to be made. I don't actually have any understanding how a decision-making occurs in those situations. Maybe you could explain that a little more? Or?
We could have a whole conference
Yeah.
on this, but I'll try to be brief, and there are materials to flesh it out in the links that I've given you. But in short, if somebody is a high support need person, they're going to have supports in their life, and hopefully, if we have people out in the community and being active and participating, there are going to be natural supports in other people in their life. So when people have a complex, for some people who are unable to go to a physician on their own, they can either have a supporter who's a natural support, like a family member or friend, or there are paid services, like the ARC of San Francisco has a health advocacy service that can be part of your IPP plan. So if you lived in supported living, let's say an adult lives in supported living in their own home and gets supports that come in, part of their IPP could include a health advocate who goes to their appointments with them and helps to support their decision making. And when there will be times, if you gave me a big enough dose of something or bopped me on the head, I might not be able to make decisions for myself either. And so supported decision-making doesn't replace a power of attorney. It doesn't mean I need a conservator, but a power of attorney form. And then sometimes people do need to make decisions for you because you're unconscious or you really can't make the decision for whatever reason. And then a supported decision-making framework is that we would try to determine to the best that we can, based on your past experiences with you and what we know your values are and what information we have, what your will and preference would be, and make a reasonable decision. And so practically speaking, what happens with my patients is we call the regional center convenes whoever they know is in that person's life, including care provider's family, whoever that is, anybody the person would want to go to. We have a meeting that includes the person participating to the extent that they can, and we come up with a decision. And we can, sometimes this has to happen in a shortened way because there's an emergency decision to be made, and sometimes we can do it in a more leisurely way. What's that? The regional center can do that. Yeah.
Okay,
Regional center
time
can sign.
for 2 quick questions because we have to close the conference.
My question is, when I go to my daughter's doctor with her, she's 22 and she's nonverbal, all the reporting comes out of me. And of course, I look at it in a certain way, but I may not be seeing everything. But they really don't touch her. They're like, okay, good, everything seems fine. When I think sometimes I think she does need an actual physical. How do I say that without, I'm already pushy as it is, without being extra pushy, if I could say that?
I support pushy. It's just good care. And just like when our patients say, "Doctor, did you wash your hands?" I think that's perfectly appropriate if somebody is providing substandard care for you to remind them that the full scope of services are needed here.
Okay. Just
Last question.
Hi. The last presenter, she mentioned about when our children get to be 26 and over, that the insurance companies, I guess if I understood it, cannot deny them services for behavioral health and mental health.
If you have a current plan that has the services, and you want to keep your adult child on your plan beyond age 26, yes, you can get a note from your doctor and make sure you get it to the health plan, and they can extend it, and it's not unusual. And it's gone on for quite a while, and a lot of people don't know that.
Okay, so do I file it with, I
Your
used to
health
work for
plan.
the state, do I file that through my retirement services, who handles it, or do I go directly to, my case would be Blue Cross?
Right, I believe you'd go right to Blue Cross, but if you're retired, you're retired, but you're not on Medicare, you're still getting, okay,
Right.
then yeah, you should be able to extend it to your child as well, your
Okay.
adult child, yes.
Okay, so in my case, I'll probably just send a letter to both.
To whatever,
Shield?
Blue Shield, yeah, you would send it to Blue Shield,
Okay,
yeah.
right, thank you.